Good morning, sorry, do you hear us?
I hear you. Can you hear us?
Yes,
Okay, excellent.
please go ahead.
Can we go live?
Yeah, sure. You're live.
Oh, okay, excellent.
So maybe Dr. Ali will give us like an introduction on the case.
Okay, so good morning, everyone. It's a pleasure to present the case that we will have today, both clinically and from CT point of view. I would like to also present my colleagues and operators, Dr. Walid Al-Harbi, Dr. Talal Al-Jabbari, as well as our guest, Dr. Given Cross, and the assistant, Dr. Shahid Al-Awad, the cardiology fellow. Our patient is an 88-year-old female who is known to have diabetes, dyslipidemia, hypertension, as well as atrial fibrillation. And she has undergone a TAVI Sapien XT 2014 size 26. She presented with angina and shortness of breath class 3 for a few months, and found to have a severe prosthetic stenosis, underwent coronary angiogram, which revealed a severe mid-LAD calcified stenosis. The decision was to actually proceed with a valve-in-valve with a volute FX29 prior to LAD revascularization due to the high risk for complications. So this is the coronary angiogram, and since I have my...
Sorry to interrupt you, but we cannot see the slides. Can we put the slide of the case on the screen, please? They are still in the live case.
Can you please run the images, please, to show the angiogram?
Okay, so this is the coronary angiogram, and you know, as an imager, it's uncomfortable to really interpret an angiogram in the presence of a hall full of interventional cardiologists. However, I'll try my best. This is right. There is no significant disease. Over the left, there is a clear mid-LAD severe lesion, which can be visualized here with what seems to be very diffuse disease and heavy calcification. Any comment, Carlos?
You did pretty well, the angiogram. I have nothing else.
I'll do that in the CT. So also we see the Sapien valve there. So for the sake of the time, the question is, what can we learn from the cardiac CT prior to revascularization in this patient? So as you guys listened to the great talk by Carlos, the coronary CT here, the first we start with a 3D map angiogram, which is showing the takeoff of the left main as well as the heavy calcification across the LAD involving a bifurcation lesion. Comment?
I think that you have said it. So we have a severe calcification starting not from the osteal-LAD. We have some healthy landing zones in the prox-LAD and extends to the mid-LAD. So I think this is something that we miss in the angiogram. It was not so clear that it was so calcified, but indeed this is a severe calcification in the prox-LAD. So we should be prepared to treat a very calcific long lesion in the LAD.
I agree. So then the coronary, in the presence of the aortic valve prosthesis, the coronary osteo position is very important, especially that we're going to deal with valve-in-valve and two layers of valve. So identifying the ostium here with a normal takeoff, left coronary and anterior takeoff highlighted, which is sometimes a challenge for intervention cardiologists, and that may actually dictate the catheter selection, as well as the wires.
Correct. So this case is a straightforward EBU 3.5 dilated, and you see that, as you mentioned, Ali, the takeoff of the left coronary is normal. So it will be some difficulty, but it will be to get through the struts of the two valves, but I do not foresee any big issue in terms of guiding support if you cross the valve.
So the coronary CTA axial, although Carlos mentioned that we don't rely a lot on the diagnosis, we rely a lot on axials to diagnose coronary artery disease or obstructive lesion. And you can see here that there is a heavy calcified lesion and extending from the proximal LAD and going down to the mid lesion where it's actually very clearly stenosed. The right is clearly doesn't show any significant obstructive disease, and the left circumflex didn't show some calcified, probably less than moderate range. The heavily calcified lesion here, which is seen in the mid LAD, is where the challenge is.
So,
And you
Ali,
can-
I was told that we have to go as soon as possible to the live, but
Perfect.
I would like to show the calcification
Sure.
reconstruction because
So
that's good. Yeah.
I will move to the calcification here. One of the things before calcification is the breast projection, and this is it has a very high impact on your decision as well as visualizing a branch lesion or any branch lesion or vessel.
Definitely, and you also avoid doing unnecessary projections because you already know that this projection will give you the perfect landing zone proximal and this one distal, so you go directly to those projections in the cath lab. You don't need to do a number of shots.
Okay, so then the next, I'll go to the calcium view, where you really can visualize the calcification and try to quantify the calcium arc.
Okay, this is important. I would suggest that we stop here because this is going to really help the operators in the sense that we have eccentric calcification proximal to the diagonal that we saw subtend 40% of the mass. This calcification is hard. Hounsfield units are more than 1,000. Then we have a circumferential calcification distally, and for the rest, we see calcifications of about 270 degrees. So this lesion needs to be modified from the distal segment to the proximal part with a lot of emphasis on the proximal part because the calcium is contralateral side branch, and that is a predictor of side branch occlusion. So a lot of work to be done before implanting the stent to be sure that the calcium is well modified. Maybe we can go to the planner and then stop there.
Okay.
Yeah.
So,
so
this is the
sorry,
virtual
we can-
planner for the predicted the FFR post PCI. This is very novel and has been recently introduced.
Very good. I would suggest we stop here
Yeah,
and then we go to the live. Thank
Can
you,
we go
Ali.
live, please, now?
Okay, we still have time.
Thank you so much.
And so Carlos, this is really recently introduced, and it shows that you could really predict what is the FFR post PCI.
Yes.
I know it has been actually introduced, but it's not validated.
Yeah, it has been validated. We validated this 3-4 years ago. We published that the difference between the prediction of the planner and the invasively measured FFR is 0.02 FFR units. So it's quite accurate. In this case, there are 3 strategies. Short stent 24, FFR 79, 40 millimeter stent, FFR 82, 2 stents from prox LAD to mid LAD with 53 millimeters in length, FFR 84. So I think that will be, James, our advice to the operators, basically to try to cover most plaque to get the patient above the ischemic threshold and try to see if she feels better after the procedure.
Another application that we did not actually go over we went quickly over it, which is the
We have to go live, guys.
Yeah.
so
Dr.
the
Walid, yeah.
this is the last point here, which is really important for securing side branch. Estimation of the myocardial ischemia prior to the intervention, which could really help you in choosing the side branch wire and or protecting stenting.
Definitely. So the diagonal, and I'm talking now to the operators, is 14% of the mass. So you cannot lose this diagonal. It's a very, very big diagonal. It doesn't appear to be diseased, but one of the technicalities of the procedure will be to protect that side branch pretty well and avoid losing that.
Thank you so much.
Thank you, Dr. Ali. Thank you. Dr. Walid, can you show us how, what you have done so far?
Okay, thank you, everyone. We'll go over the base of operation, what we've done. We went through left femoral ultrasound guided with a 7 French system, with a guide extension of 7 French. And we'll show you what, with the images. Can you see the floor images? Audiovisual, can you show the images of the floor, please? With the hemodynamics. Okay. So you can see this is the fluoro that you saw after the TAV and TAV. And we try to engage the left main, but we're not able to cross the strut. But with cusp injection, we're able to really opacify the vessel, so we were sufficient with that. And what we did, we wired with the Xi'an blue to the LED and IBIS it. Can you show the IBIS, please? And Kevin will go over the IBIS.
Yeah, so a couple points here. You know, it's probably maybe once a year, if that I do the Judkins left guide. So they tend to be relatively non-supportive, especially for a calcified case. You can see based on the angle of takeoff from the ascending arc, just not a lot of space. So at least in my mind, a Judkins left prefer have to versus an undersized EBU3. I think Carlos had mentioned the EBU3.5, but that'd be a little bit unfold in this particular core valve with a valve and valve. So we admittedly went with a potentially unsupportive guide, hoping that we'd be able to overcome some of the deficiencies of that with a guide extender. So, you know, we have a 7 French guideliner in the 7 French system, and despite inchworming balloons at the cage and trying to do everything we could to extend the guide extender past the cage to get better selective angiography, we were unable to. So a little bit of what we see here is we're getting mediocre angiogram pictures that can see well enough to do the work, and then, you know, having some practice at IVIS-guided PCI with minimal contact, more in intervascular imaging, both for prepping, but also just making sure the adequacy of our stenting result eventually is good, because we're not able to get perfect angiograms. We could fight more with the TAVR cage. You know, we tried to inchworm with a 3.5 NC balloon, tried to get the guide extender through, we couldn't. I can actually show you the IVIS. We tried to do an IVIS of the cusp just to see what the problem was. We see that we tend to be biased. The struts, I was surprised. It looks like space. A little bit surprised in our inability to inchworm the guideliner through, but we've been doing it with this base of operations. So this is the, can take you up to the first IVIS run that we did, if you can show it. AV team, can you bring up the IVIS, please?
The IVIS there.
Can you guys hear us okay in the auditorium?
Yeah.
Panel, are you there?
Yeah, we can see the IVIS, Kevin.
Great, awesome, James. How are you, James?
All good.
So I'm going to take you through the first IVIS run. Unfortunately, we had a little bit of technical difficulty and didn't have the sled initially to do the pullback. We fixed that for the subsequent runs, but this is going distal to proximal. I think as Carlos nicely articulated, there's a very good landing zone distal here in relatively normal segment. And we measured in the normal segment, we're running about 3.0, as you can see here, for a reference, 2.6, 2.9, probably about 2.75 to 3.0. And there was some discussion of what size stent that we'll place that we'll talk about. And then as you come in, this is before any modification. You can see the eccentric calcium through the mid segment. And then as called out by the CT, there's about 270 degrees in the proximal portion.
We have one question from the audience, Dr. Ayatabi. Go ahead, please.
Yeah.
Nice case. Nice case, Walid. But you see, I was wondering why the CT didn't comment on the skirt and the relationship of the two skirts in front of the coronaries. And I thought this is very important. I was waiting for the CT analyst to mention this. And it seems that there is some issue with that because you couldn't cannulate directly the left main. So you have to really pass wires without direct cannulation. But this is, I think, is very relevant information on CT interpretation. What do you think, Walid?
I'll let Carlos comment on that.
Yeah, I think what you're looking to do here is fill in the gaps that the IVIS doesn't give you. So obviously the ultrasound, if it doesn't penetrate deep to the IVIS, it doesn't tell you the density or the volume of calcium. So and that's what we're getting from the CT. So they're sort of complementary. In this still, for example, you can see at 3 o'clock there's reverberation artifact to the right. That tells you the calcium's relatively thin. Whereas at 6 o'clock, there's no reverberation artifact, and therefore the calcium's denser. But that's a very rough way in terms of imaging to understand density. And I think CT is bridging that gap, Carlos.
Yeah, so I think that the information is indeed complementary to each other, but when you think about where CT adds to IVUS particularly, well, I think you were on spot, James, in the sense that you cannot see the thickness of the calcium with IVUS, so basically CT provides you that additional information about the thickness. Also understanding where the calcium is located relative to the side branches. Looking at the calcium in 3D is completely different than looking at calcium in a cross-sectional way. You kind of really understand what is the shape of the calcium, how that calcium may influence the PCI procedure, and what are the risks of the other side branches. In addition to that, the information about the density is something that you cannot get for intravascular imaging and is extremely relevant, specifically in these heavily calcified lesions where you need to do advanced plaque modification.
Yeah.
And
Carlos, may I interrupt? The question from the audience, I think Dr. Mohammed Al-Ataibi, his exact question is that about the two TAV platform, the frame relationship to the left main ostium regarding engagement, how that can help us.
Well, in this particular case, I think that the fact that you have two layers of metal before the ostium of the left main, if I understand the question well, is of course very challenging. Now, when you have only one layer, sometimes it's easy to understand what would be the best approach to cannulate the left coronary artery. In this case, we try to play with the windowing of the CT, but because we have two layers of metals, it was extremely challenging to understand what would be the best approach. So I fully agree that that is an extremely important comment in terms of vessel engagement. In this case, we were limited by the fact that the blooming artifact was too high at the level of the ostium of the left main.
So I have a question to Dr. Walid. How easy was it engaging the left main with the double stent in place? Was it challenging or was it just easy? How easy was it to engage the left main with the double stent in place?
Well, we had difficulty to really engage selectively to the left main here. And despite different techniques, as alluded by Kevin, that we did try to anchor, we tried to balloon the wave within the frame and the cusp, but without success. But we were able to deliver devices. Stents, so we're going to see how this is going to be delivered, but we really had a challenge to selectively engage the left main here.
Yeah, the other point, I mean, this angiography we're getting with a semi-selective injection is adequate when it's supplemented with the IVUS. And so we talked about, further informing, de-engaging.
Maybe we can have some question to the panel here.
We're in
Yeah.
a place where we're able to do the case effectively with this conditioning,
This question
with the IVUS supplementing to be able to make sure that our stent goes in well.
Yes, I have
So
a
Dr.
question for Dr. Carlos.
we have one question from the
This patient
Dr.
having
Hassan.
two valve and in your CT-PCI will go for virtual stenting of this one. Is going to affect your delta changes in this case, especially it's your case you presented is not like a usually straightforward case. There is no valve or there is no severe aortic stenosis. So what do you think about virtual stenting in this case?
So when we validated the virtual stent technology, we included cases that underwent rotablation and calcified disease. So we're pretty confident to say that it's pretty accurate in that regard. Now, what we saw on the slide is that in order to get sufficient revascularization or a sufficient degree of functional revascularization, you need to treat the whole segment. So if you go with a short stent where the tight lesion is, you will end up with an FFR of 77. And if you put two stents long, starting from the, let's say, proximal AD to mid LAD, where you have good landing zones, you get at 82. It's not perfect, 82, but I think everything above 80 will guarantee better afterwards.
Show you what they've done.
Dr. Walid, we have one more minute, sorry, because we have to go for the opening ceremony. So can you show us what you have done so far, like your final result?
So we elected after the IVUS run to use shockwave lithotripsy. We used for the mid-segment with a 3.0 subnominal. And then we creeped up to a 3.0 nominal. And then we used a 3.5 after the IVUS run didn't show really sufficient fracturing of the proximal segment, as Carlos alluded and expected. And And after that, the 3.5 shockwave balloon, it really cracked well on the IVUS one after that. And now I think really it yielded the whole vessel, the mid and the proximal segments. And we're ready to go ahead and stent it. Kevin?
In the audience there.
Ask them if they've done an IVUS post-IVL. Have they repeated
Dr.
the
Hind, are you able to see the angiograms from us?
Yes. Did you repeat the IVUS after the IVL?
Yeah. We've done that twice already.
So can you show us the IVUS after IVL?
So this is after a 3.0 IVL delivered mid and proximal. And we did have what seemed to be a little bit of wire bias toward the calcium. So the question here was, do we see fractures? And is in particular the proximal segment prepped well enough? Because this 3.0 IVL balloon size was chosen based on the distal reference, but we were worried it would be a little bit small proximal. And we were also worried that we would not have enough pulses left to modify this long segment that we saw quite nicely in the CT. So you can see this is after 3.0 IVL, mid to prox, a 3.0 balloon, mid to distal, and a 3.5 balloon high pressure proximal. So the question is here, the adequacy of vessel preparation. The balloons looked like they were well expanded in the mid segment, but there was a little bit of potentially constriction and asymmetric expansion proximally. So a combination of that balloon behavior, you see nice fractures in the mid segment here, there, but we were worried that we'd not done enough prep in the proximal segment. And you can kind of see here, there's maybe one fracture at 3 o'clock, but based on the balloon behavior, we felt it was necessary to do some further modification with a 3.5 IVL in the proximal segment. So we
Sorry,
performed
Dr.
that.
Walid and Dr. Kevin. Sorry, I apologize, but we have to stop the live transmission because we're moving to the opening ceremony. Thank you so much for the nice case and excellent work. I would like to thank all the speaker and the panel. And unfortunately, we didn't have enough time to go over like more discussion and question, but we had an excellent session that elaborate the use of CT in complex anatomy and how we can tailor our procedure and helping and selection of the guide, the calcium modification, and the approach. Thank you so much.
Yeah, we'll touch base with you.